we have a very good friend and a cornea expert of national and international repute, Dr. Rishi Swarup from Hyderabad, and he's going to dwell into nuances of how to have successful outcomes in cataract surgery when you are already dealing with corneal disorders. Over to you, Dr. Rishi.
Thank you, Vardhaman, for involving me in this lovely course. I wish we had a little more audience though. But anyway, this is what you expect at 8 o'clock in the morning. So when we talk about cataract surgery in corneal disease, it's cataract surgery in the presence of dry eye ocular surface disease, presence of a scar, which may be varying from mild to severe scar, eccentric to central scars, presence of cataract, compromised endothelium and its implications, irregular corneas, which may be vary from mild to severe irregularity. Some of these irregularities could be from scars or from ectasias also, or post-RK kind of eyes, and then of course eyes that have had some sort of a keratoplasty, either penetrating or lamellar. One of the common conditions that you will come across is conjunctivochalesis, and that will cause a lot of irritation and watering to these patients post-operatively. So, if you notice conjunctivochalesis during your cataract evaluation, it's a good idea to address it intraoperatively, either using a cautery, or you can surgically excise the redundant conjunctiva, so that these patients will not trouble you post-operatively. Otherwise, you'll do a good cataract surgery, but they'll keep complaining of watering and irritation, and everything that you do will go to naught. When you talk about a scar, typically, we describe it as nebula, macular leukoma, but rather than the density of the scar alone, I think the location of the scar that is really important, and the size of the scar, and of course density does play a role. So, if it's a small eccentric scar like in this picture, which is not really affecting your topography or visual axis is clear, it will not hamper your visualization or the visual outcome, then it's, I think, a good idea to just go ahead with your regular phacoemulsification without really modifying too much, and you can just do your routine surgery. If it is a paracentral kind of a scar, then you can do a modified phaco, in which basically you are doing a regular cataract surgery and combining it with some special maneuvers, like use of, say, an endoilluminator, or you may use staining of the capsule or other tools to improve your visualization and outcome. If it's a dense scar, then which is going to preclude your visual outcome, then it's a good idea to address the scar with a keratoplasty alongside, which is called a triple procedure. So, this is just an is there a pointer? This is just an example of phacoemulsification in a scar. You can see the moment you put dispersive OVD, suddenly your view improves quite a bit, and that's because the surface becomes more smooth. So, everything becomes a lot more visible. This one, right? Yeah. Endoilluminator, I think, is another tool that every cataract surgeon should have. Routinely the retina specialists use these, but they are available standalone as well. You don't really need to have a retina machine for it, and it's just a small LED light, and you can connect your light pipe to it, and it gives you a very good visualization of structures inside the eye. So, it can be used for all steps of cataract surgery, and also to visualize other things that might happen, like a desmus detachment or a vitreous loss or a capsular tear. All of these can be seen very well, especially in opaque corneas. So, this is just a case example of, I am sorry? No, through the limbus. You can put it inside the eye, or you can even put it on the surface tangentially. Yeah. So, this is just one of the cases which had a chemical injury. We did at that time we were not doing SLET. So, this was a CLET, which is limbal epithelial transplantation, and then the patient ended up with a reasonably okay ocular surface with some peripheral scar and vascularization, and that scar caused significant amount of astigmatism, as you can see in this picture. So, we did go ahead and did a toric IOL in this case. You can see this fairly regular astigmatism, even though there is asymmetry. There is not much of skewing, and that kind of causes a reasonably acceptable outcome when you use a toric IOL, and that is what we used in this case and got a very good result. Compromised endothelium can vary from just guttate changes to frank bullous keratopathy, as you are seeing in this picture. So, if it is just guttate changes with no edema, just doing a careful phacoemulsification with explained prognosis may be good enough, and you tell them that there is a possibility of a keratoplasty later. If there is mild edema, which means there is no clinical edema and the Paki is less than 650 microns, and you can still go ahead and do a careful phacoemulsification, but tell them about the possibility of keratoplasty. If it is if there is clinical edema and frank bullous changes, etc., then of course you don't have a choice but to go ahead and do a triple procedure, and usually we combine an endothelial keratoplasty with the cataract surgery. Now, when you see in the second scenario, sometimes you don't see any clinical edema, but if you ask the patient a history, they will give you a history of morning blurring of vision. Then in such cases again, it may be an indication that the endothelium is not able to cope, and you will eventually need a keratoplasty. So, this is a post graft eye, but it could be a Fuchs, it could be any other situation with a compromised endothelium. So, principles remain the same. You want to minimize the endothelial damage caused by your maneuvers. So, you want to do soft shell. If it is a graft, you want to make your wound outside the graft, in the bag, slow motion phaco with hyper settings. And in such cases, better to avoid hydrophilic lenses, because if you require an endothelial keratoplasty, hydrophilic acrylics we know can have IOL calcification when it comes in prolonged contact with air. If irregular corneas, the three common indications situations are pterygium, post-RK, ectasia and keratoplasty. I will avoid the post-RK and ectasia because they are going to be covered later. Pterygium is something we see very commonly, and of course post-keratoplasty I will cover. So, when you think about a pterygium, it is a chicken versus egg situation. Should you address the pterygium first, or should you go ahead and do the cataract first and then see if you need to do something about the pterygium, or both together? I think the decision tree depends on the size and activity of the pterygium and whether or not there is pupillary involvement, and if there is distortion of the cornea on topography. So, topography is a very useful tool when you see a pterygium. Even if it is a peripheral pterygium, I think it is a very good idea to do a topo and see if there is any irregular astigmatism being caused by it. If it is, then it is a good idea to address the pterygium first, give a gap of 3 months at least, and then do the cataract surgery, because corneal remodeling can go on for 3 months. If it is not affecting the central cornea so much, you could go ahead and do a regular cataract surgery if it is a non-progressive or atrophic pterygium, and it is completely ignore it. If you are thinking of doing a toric IOL again, please remove the pterygium first and only then give to a toric lens after 3 months, because the corneal shape will keep changing. Of course, if it is a fleshy mass like this, you have to address that first. It may be reasonable to do cataract surgery with pterygium together, but then in such cases no question of doing a toric lens. You must go for a regular monofocal lens, because the spherical because of coupling effect, the K value, the net K value will remain the same. So, it may not matter so much. So, I will just run through this little video to just see if I can. I am not able to. We will skip this video because it is too long. I am going to skip this as well as this. So, one of the things to remember in a post-RK is try to do scleral wounds, especially if the cuts are more than 8. Otherwise, you can end up with this is my first post-RK video. You can see it is an old video, and I was stupid enough to do a clear corneal incision, and you can see I had to put lots of sutures, which ended up looking like this, a very funny kind of suturing. Okay, so cataract surgery and corneal grafts. When you talk about in the situation with grafts, it's either after a graft or you're doing a triple procedure together. So after graft, technique really depends on whatever works well in your hands and is least traumatic to the cornea. So if cataract ECC is good for you, by all means, or SICS, whichever is least traumatic. In fact, many of my post keratoplasty cataracts are small incision cataract surgery, because in my hands that's the least traumatic to the endothelium, especially if the cataract is intumescent, etc. I think, or a hard cataract, you will end up damaging the endothelium with the phaco energy. So this was one such case, had a therapeutic keratoplasty, and soon after the keratoplasty developed a intumescent total cataract, shallow AC going into phacomorphic glaucoma, and so we had to kind of urgently go ahead and do the cataract surgery, even though all the sutures are in. Typically, you would want all the sutures to be out before you do a cataract surgery, but here we didn't really have much of a choice. And as you can see, we've managed to decompress the lens, and the anterior chamber could be expanded, and we could do a safe small incision cataract surgery in such a situation. When you're doing a phacoemulsification, some important principles to remember: wound location, try to be outside the graft. If it's an eccentric graft, choose a site where you have more peripheral cornea to work with. You want to use as small an incision as possible and do the entry outside the graft as possible. And remember that these wounds ideally should be sutured, because your wound will induce a lot more astigmatism, and you can control that, and they also can tend to leak more often. Again, if it's a penetrating keratoplasty, you want to follow the principles of compromised endothelium, soft shell, in the back phacoemulsification, etc., etc., slow motion, the principles which we talked about earlier. IOLs, it can be challenging to calculate the lens in some of these cases, so use the appropriate tools for it. Toric IOLs can be used if the astigmatism is more regular than irregular. Avoid multifocals and EDOF lenses as much as possible, and again avoid hydrophilic acrylic lenses in case you need to do an endothelial keratoplasty later. Piggyback toric lenses are again a simple, very useful tool for refractive surprises which you might get in these cases. So, this is just one case, phacoemulsification after a DALC. You can see there was some amount of asymmetry, but the patient got a good outcome. This was another case just to highlight a scleral tunnel is a good idea for all grafted eyes. I learned this the hard way in one of the cases. So, this is a patient who had a very high cylinder. We used a custom toric lens and got an excellent outcome. So, this is another patient who had a DALC. You can see very clear graft, toric lens, and patient got beautiful results. Now, this was one case. I just want to show you one video. I am trying to do phacoemulsification after DALC, and you see I felt a give, and at that time I didn't realize what was happening, and I went ahead and tried to do phacoemulsification. You see I am trying to get the cortex, nothing's coming. So, what I have done is I have detached the Duas layer, and now I am going to make a hole in it with my phaco probe. There you go. And that was a disastrous result to a very nicely done DALC. Anyway, we were able to salvage it with the endothelial keratoplasty later. After endothelial keratoplasty, it's pretty much the same as a routine cataract surgery. Just be sure that you don't detach the endothelial graft, and again you have to respect the endothelium. I think I'll skip the triple procedure. So, just one thing about the triple procedure. Typically, in a penetrating keratoplasty triple, you try to do an open sky, but many of the times if the cornea is too opaque, it's a good idea to just do a lamellar keratectomy, just enough to be able to see, as I have done in this case. And once you have finished the phacoemulsification, then you can remove the button and then go ahead and do it as a penetrating keratoplasty triple. So, to conclude, cataract surgery is possible in eyes with compromised corneas, and it's a huge spectrum of conditions. As you can see, I've got so many videos, but obviously time is of the essence. It's important to select your intraocular lens properly and assess the case well. In most cases, closed chamber phacoemulsification is possible, and you can get good outcomes in a majority of these cases. Thank you.
Thank you very much, Dr. Rishi. I think it was a very nice and quite comprehensive in a actually quite short time. I think a couple of pearls that you shared were very important. I think most people would not know that hydrophilic lens should be avoided in these scenarios wherever you expect to do a DSEC in the future, or along with the DSEC surgery because of the opacification of the lens. That was a very nice pearl, and of course all the other pearls that you have shared to make it easy for people to make it clinically, let's say, relevant and give more optimal outcomes to our patients with cataract and corneal disorders. So thank you very much for your excellent deliberations. Thank you. Thank you. So now we would like to have our senior glaucoma expert, Dr. Rajul Parekh sir. Sir is well known for his advanced glaucoma surgeries, especially along with cataract procedures, and is the best person to give us the best tips for cataract surgery in presence of glaucoma. So over to you, sir.
Yeah, thanks very much. Okay. So good morning, everyone. So
Can we have the slides, please?
Yeah.
Sure. Perfect.
So the talk I will divide into two parts. One, the surgical decision making, and second, in glaucoma patient is very imperative that which lens you choose. So because the cataract surgical technique would be more or less same in open angle glaucoma, there are some few things you have to remember in angle closure glaucoma, but decision making, because in glaucoma patients whether to do only cataract surgery or you have to do only glaucoma surgery first or combined surgery, that is more important. So yes, they do coexist because glaucoma prevalence is high. As age increases, the risk of glaucoma increases, and cataract is of course age related. So is of course both coexist, and that's why we should know. And in angle closure, the risk of complications is little more in cataract surgery, but open angle glaucoma is not a big issue. So the pre-operative assessment of a glaucoma patients in view of cataract is very important. So a thorough examination, especially looking the corneal status, which we do all the time, but conjunctival status is very important, because if you are doing combined surgery, then whether to do trab or any other surgery, that's why conjunctiva is very important from the glaucoma point of view. Pupillary dilatation, and then most important thing when it comes to glaucoma assessment, structure and function, because depending upon the damage I would decide that only cataract surgery I'll be doing, or I'll be doing combined surgery or a trabeculectomy first. So this is very important. And secondary causes. The secondary angle glaucoma like NVI, uveitis, they would require special care from the glaucoma point of view. So if the patient is, now I don't use pilocarpine, but there are patients who are on pilocarpine. So if you are planning cataract surgery, at least try to stop pilocarpine a week or 10 days before. Otherwise also, what you can do, that intermittently keep dilating the patients. If the patient is on chronic pilocarpine, that helps keeping the pupil mobile. There are certain, a few examples. You get all, if you dilate, you can see pseudoexfoliation. Now this is a traumatic glaucoma. You see there is a clear area here which suggests that most probably patient has a pre-existing PC rent, and which he had. Structure function, as I mentioned, because that would decide my management plan. So decision, you have three options: only cataract surgery, 2-stage, when glaucoma surgery would come first, and combined surgery. So, and why is important? Because the goal is totally different. When you do cataract surgery, the objective is vision should improve and healing should be very fast. With clear corneal, we ask patient to go from second day or same day they can go for the work. But glaucoma surgery, I don't want the trap to heal very fast, whatever surgery I do. And my primary objective to preserve whatever the patient vision has. So only cataract surgery, patient is early glaucoma, IOP well controlled within 2 medications, and now with the recent experience in PSC or early PSCG, if the patient is more lens thickness or high lens word, I would consider only cataract surgery even if the patient is on 3 medications. On other hand, you can see this patient, there is a macular split on size 5. Here my primary objective is to make sure that glaucoma he should not get wiped out. So I would do a trabeculectomy first and cataract later on after 3 to 4 months. Combine all intermediate cases, patient is on 2-3 medications, borderline IOP, where cataract is a major issue, or patient is not tolerating medication properly, or logistic issues, sometimes logistic issues do come. And now with the advance of mix, even patient with 2 medications, if they don't want to use medication, I would consider phaco-mix, and mix we have lots of options. I'm not going to discuss that, but again the mix advantage is that no post-op recovery, in a sense that patient can start work from the next day, just like cataract surgery. So that's the advantage, especially if you are doing ab interno goniotomy, bang, KDB, eye stand. GET sometimes can cause more hyphema and may require a delayed recovery. So planning as on table glaucoma patients, especially with advanced glaucoma, no sudden decompression. Pre-operative, if the pressures are too high, I would give mannitol, not in every patient. Avoid tight speculum, especially in the angle closure, because they have a shallow orbit. The risk of positive pressure is very high, and you will keep getting iris prolapse from the wound. A limited hydro or careful hydro with large axis in angle closure, that is really helpful. Avoid anterior chamber fluctuation, and if you are doing trap, releasable or adjustable suture. When do combined surgery, now with 2 sides, I do clear corneal, temporal and superior trap. Fornix limbus, your choice. I do fornix from the beginning. If you are doing limbal base is absolutely fine. Mitomycin, when you're doing combined, I use mitomycin in all my cases unless the conjunctiva is very fragile. And there is a reason World Glaucoma Association consensus very clearly says that the combined, the glaucoma surgery success rate is not great. So I would like to use mitomycin to make sure that my trap works better. One side, two side, as I mentioned, your choice, limbal fornix, your choice. But if you are using mitomycin, fornix makes more sense because you can go away from the limbus and put mitomycin posteriorly. And if you think that the glaucoma is a pressing issue, go ahead only with the trap. Don't consider combined surgery because trap alone has a much better success rate compared to combined surgery. Post-operative, again, it's not like cataract. Even if you have done only cataract surgery, you have to make sure that IOP doesn't fluctuate very high. So you have to take more care unless only cataract surgery in a normal eye. If you have done trap, then make sure that you look the conjunctiva, the corkscrew vessel, because in that case you may have to give 5 few injection antimetabolites. You may have to do the release the early, may have to teach patient indirect massage. The trap management is always, you have to be more aggressive and more careful. So this is one of my combined patients. After 6 weeks of trap, you can see very nice bleb. Now I'll just give few examples. And I have not deliberately kept the cataract surgery video because that would be, everybody is going to show cataract surgery video is going to be same. As I mentioned, in angle closure, you have to be little careful, otherwise cataract surgery is more or less same. What extra you have to do? So this is one of the patients, 55-year-old male, angle closure glaucoma, but if you look the refractive error plus tail, axial length of 20, this is nanophthalmos. And nanophthalmos with angle closure with cataract, they have very high risk of uveal effusion and complication of suprachoroid hemorrhage. So what extra care you have to take? That is what I am more interested. So you do a prophylactic sclerotomy with the sclerectomy. You can do two side, you can do one side. In this patient I just decided to do one side, but this is what is important. 3.5 millimeter from the limbus, you make a 3 millimeter, go up to the suprachoroid space, and you can leave it. And this patient, I also had done the sclerectomy before I did the sclerotomy. So you can remove the partial thickness sclera because the sclera is thick. That is the reason patient gets uveal effusion. So that you have to be careful. Second case, this patient had a failed trabeculectomy, and we had planned the cataract surgery. So in this patient, you can do retrap, but this patient we decide to do the MS glaucoma along with the cataract. So what you have to do, cataract surgery I finished. When you have a pseudophakic eye, it makes sense to put the tube behind the iris, so it remains away from the cornea. The risk of corneal decompensation reduces. In most of my cases now I make a scleral tunnel, so you don't have to use sclera. 4 millimeter from the limbus, and here I gone little deep, so I can go behind the iris. And you can see this is, I have constricted, even if you don't constrict is fine. And you can see that the tube is here behind the iris. So it makes surgery very, in long term, the cornea remains much safer. This is third case, 68-year-old female, POAG, she converted to PACG, which is very common. That's why gonioscopy, routine gonioscopy is very important. We did iridotomy. Subsequently, her vision was 6/6, but she was completing a visual care and she had significant cataract. There was a likely progression. She was on 4 medication, but on AIOS2025, the lens work was 850 micron. So we decided to do only phaco IOL and not combined surgery. She was on 4 medications, and after 5 years, she's only on 1 medication, and that's why in PAC and early PACG, if the lens voltage is very high, you can consider only cataract surgery and keep trap for later on if at all required. So the conclusion, the first part, of course, surgical decision making is individualized. You cannot have an umbrella that this patient, this surgery, but individualized approach is what is required. Now the second part is more important, which IOL you will use in glaucoma patients. So we have a multifocal trifocal IOL, then we have true EDOF IOL, and we have monofocal IOL, and we have modified monofocal IOL, and toric. So I'll just go step by step. Multifocal trifocal, the studies are very clear that the glare, halos, and contrast all are more. The contrast sensitivity is drastically reduced in glaucoma patient, and glaucoma patient anyway have a reduced contrast sensitivity. So you should be very careful. I would say that definite glaucoma patient, you avoid multifocal trifocal lenses. So because of these all three reasons, not only that, they also have an effect on visual field. So if you look this study, the phakic IOL, monofocal IOL, and this is trifocal, multifocal IOL. The sensitivity is drastically reduced, which affects your clinical judgment. So this is one of the reasons, but main reason is the contrast sensitivity drastically reduced in glaucoma patients, and multifocal, trifocal will worsen that. So you should avoid that. True EDOF, again, if you look the studies, the contrast is worse in even in myopic eye with all true EDOF. So ideally, I would avoid the true EDOF in definite glaucoma patients. Right, modified monofocal, which is the Ihans and Clarion, they are much better tolerated, and I'm using that for last 7-8 years in most of my glaucoma patients. Very good results, and studies also says that the glare contrast sensitivity does not get affected. The results are as similar to the monofocal IOL. So modified monofocal is my choice in glaucoma patients. If you are doing combined, I would not recommend toric IOL because the IOL can get rotated and the things become more difficult to manage. So the monofocal lenses if you are doing combined surgery. Post trabectomy, if eye is stable, you can think of toric IOL, but you have to be careful because I had bad experience in couple of patients. Even I had done trap 1 year ago. So you have to be careful. If you are doing angle closure post trap, you may get surprises. So I would avoid anyway. I would avoid trifocal, multifocal, but you should be careful. I would avoid that. So all glaucoma suspect, if the disc damage is not much, you can consider, but as a practice, I don't recommend. Pseudoexfoliation, again the small pupil, IOL centration can be issue. The monofocal modified is better. It should be case based. Better to err on the side of caution. So rather than be aggressive about the newer lenses, I would say that monofocal or modified monofocal is a better choice of selection in IO as well as IOL is concerned. So there I end my talk. Thank you.
Thank you, sir. I think it was a amazing overview, and thank you for covering also the lens choice. I think two most important things which of course came across. One was that in this beautiful case you have shown when patient was already on 4 medications, just doing phaco in angle closure with the lens fault is high and the thickness is good. Yes.
Because both presses the angle.
Right.
And once you do that, the angle space opens up.
Yes.
So they work just like extra trabecular flow.
Right,
So
sir.
the thing is that if your trabecular management is damaged,
Damaged,
then
yeah.
you may require trab later on.
Correct.
But you can always go after 3-4 months.
Correct.
Rather than
Right.
combine.
So it is always better to put it in the second go if it is required.
This
Yeah.
patient had progression, but the disc was not very bad.
Correct.
If the same patient had 0.9 bipolar,
Right.
I would have definitely considered.
Right.
The disc damage was not bad.
Right.
There was progression, but the fluid was very still not bad. So definitely in those patients I would do only cataract.
Sir, one last question is like for patient who has very advanced glaucoma, has already undergone a trabeculectomy, pressures are under control, has undergone trabeculectomy in the past, is 0.9 plus cupping, and now requires only cataract procedure. What is the possibility of having a wipeout phenomenon? And yeah.
If you look, the main issue about this wipeout,
Right.
how the people have defined split fixation.
Right.
So most of the time people have defined split fixation on size 3, which is not ideal.
Okay.
So the size 5
5.
macular program, which I showed,
Right.
if there is a 1 0,
Right.
that is the way you should define wipeout.
Right.
In that case also, when I was in Bangalore, we had 35 patients. There was not a single wipeout. But if you look, because the sample is too small, if you calculate the confidence interval, the upper limit is still only 2%.
Okay.
So the wipeout is very grossly overrated.
Right.
But when you're doing surgery, you should know how to operate.
Right.
So if you are confident about your surgical skill and take proper care, then wipeout.
It's very
See,
rare.
if you
Correct.
have too much of AC fluctuation,
Correct.
if you, otherwise what happens in lots of centers, when you're doing combined or post step, if you're giving block,
Right.
the block is given by junior, then they
Right.
put excessive
Right.
pressure,
Right.
some places they put the pinky ball.
Right.
Those things should be avoided.
So any form of pressure fluctuation should be avoided. Right.
Care,
Right.
then the risk of wipeout is
Yeah. Even the highest risk will be 2% is what you're saying. So compared to, so that is, Yeah, so it is required for basically patient counseling. Right, 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 right. Perfect.
Sir, I have a question. Like in a case of nanophthalmos, like how many days in advance you like to do sclerotomies or on table, same time, same time? Hmm. Yes. Yeah. Yeah. Yeah.
Just very nice presentation. Congratulations, really, you covered everything. I'm just highlighting that we should differentiate between low tension glaucoma and other case of glaucoma in the choice of the IOL, because usually low tension glaucoma affect the central part. So even the enhanced monofocal in these cases are not recommended. Usually, if we found that the central part of the field is highly affected, so monofocal, simple monofocal will be better visual performance for the patients, better than even monofocal plus.
Just or on the side of one. Thank you, sir. Thank you so much. So now we will go to our next presentation, which is also a very important dilemma for all our ophthalmologists, is cataract surgery in presence of uveitis, and of course, no better than a very good friend and a uveitis expert of national and international repute, Dr. Partho Pratim Datta Mujumdar from Shanganitralaya, who is also a very active leading office bearer of Uvea Society of India. So thank you, Dr. Partho, and over to you.
Thanks, Berthaman. Thanks for including me in this wonderful session. So I'll be talking on managing a cataract in presence of uveitis. So you need to understand that unlike the other conditions which will be discussed in this session, that the outcome of a cataract surgery in uveitis depends on two things. One is how good is your pre-op treatment and how good is your post-op. I assume that all of you know how to do a cataract surgery, so I don't need to teach you about that. So I'll just try to break one myth with that if the eye is quiet for 3 months, then we can go ahead with surgery. So this is sometimes actually not true. I'll give you two case scenario. You see here, 128-year male complains of recurrent attacks of uveitis in past, HLA-B27 positive, last attack of uveitis 4 months back, so it's quiet for 3 months. And this here not on any systemic medicine, and here you can see a 61-year-old female, recurrent attacks of uveitis in the past, known case of VKH, last attack of uveitis 6 months back. So not on any systemic medication. So these are the patient, if you are going for a cataract surgery without any starting a medication or waiting for at least 2 to 3 months, you are definitely going to burn your finger. So this is very important to understand. So before you touch a uveitic eye, you need to understand the three important points. So the first, number one, is that identify the etiology of uveitis. If it is a case of Fuchs uveitis, if it is a toxoplasma, white dot syndrome, go ahead. Directly you can go ahead with a steroid cover of 4 to 5 days. But if you are dealing with juvenile idiopathic arthritis, HLA-B27 associated uveitis, Vogt-Koyanagi-Harada disease, idiopathic anterior uveitis, or tubercular sarcoid uveitis, or viral anterior uveitis, then you have to be very, very careful, because these are the entity are known to have a recurrent attack of uveitis even after the cataract surgery. So you have to be very, very careful. Second important is understand that whether the patient is on any effective immunosuppression for a sufficient amount of time. This is very important, that effective immunosuppression. It doesn't mean that the patient is on 5 mg oral steroid or for 5 days. So effective immunosuppressions for a sufficient amount of time is the key here. The third one, beware of two clinical signs. One is extensive posterior synechiae. These are the patients with high risk of postoperative inflammation, including CME. And second is that macular edema. So if there is a history of macular edema, the severe it can have a severe post-op inflammation and can have greater risk of macular damage also. So management of synechiae, I just want to highlight that occlusio pupillae, you have to understand that whereas sometimes the fibrotic membrane will cover the pupil. So sometimes this membrane is so tough that you can't break it even with any instrument. So here in cases if the patient is having any PI, sometimes you can use the PI to inject the viscoelastic, which will lift the iris little away from the lens, and actually you can take a 26 gauge needle as I have done in here, and you can actually prick and go make a opening into that fibrotic membrane. And second important thing is that the peripheral anterior synechiae, you have to make a room for, as you can see in this case, you have to make an entry for that, but don't go and try to make a wide dissection of this membranes, because sometimes it can actually lead to the Descemet's membrane detachment also. So try to do minimal separation, try viscoelastic to use that, and if it is not working, then you can take a spatula and try to dissect it. So management of small pupil, many of you know, because you in your routine case also you handle a lot of other small pupil cases, but there are so many devices available. I won't go into the details of that, but sometimes you have to understand that the large pupillary membranes can be incised with the microvitrectomy scissor and can be stripped from the pupillary margin before you put that. So as you can see this case here. So sometimes it's important to dissect the membrane before you apply the ring in uveitis. And coming to that, there are so many options. If you want to use the Coughlin hook, you have to remember that if the pupil is very small, then it works better, because the smaller the pupil, better will be the dilatation outcome with the Coughlin hook, and better to avoid the Coughlin hook in eyes with very shallow anterior chamber, because you can damage the endothelium accidentally. So Grischerver hooks are much better. It's a very good instrument for that, but only one word of caution, that don't avoid placing these hooks very anteriorly in the cornea, because it can actually lead to the tenting of the iris tissue, and which can actually be damaged while entering into the eye with the phacoprobe. So coming to the rhexis, again just 2 points I want to highlight. Avoid very small rhexis, because in uveitic eyes are notorious to develop the capsular phimosis. So be careful that, and also don't try to avoid the very large or eccentric rhexis in cataract surgery in a patients with uveitis. Why? I'll show you here. These are the cases I'll be showing. These are all in the bag lens implantation. You can see that IOL has been placed in bag, but you can see here with that UBM is showing, because it's a large eccentric rhexis, the square edge of the IOL is actually touching the iris. So whenever there is it's touching the iris, so it is causing a subclinical inflammation, and the patient is developing the inflammation. I'll show, you can see the schematic diagram where I have tried to show that how the square edge can actually rub the iris. So similarly, this is another case you see here. This is a large rhexis, eccentric rhexis, and with a jonular laxity, and you can see that IOL has popped up little and causing significant inflammation. And also you have to understand, when you are using Grischerver hooks, sometimes you check thoroughly that whether you have missed any cortical piece or anything, because sometimes the Grischerver hook, they causes the tenting of the iris, and small piece of cortical piece or the epinucleus segment can be actually lodged underneath the iris. So you can see here there is a small piece lying there, and it was a cause of inflammation after the surgery. And you can see here the retained lens fragment. So also in uveitis patient, try to actually always use the better quality of lens. See, this patient of uveitis came to us with complete opacification of the IOL. So we explanted this IOL. I don't have any financial or anything, but I just want to show you that this IOL, when we took out, we could see some sediment. So what we did, we just took the this IOL material for the electron microscopy picture, and you can see that electron microscopy is showing, this is, you can see, is an inflammatory cell, clump of inflammatory cells. It's actually eroding the lens surface. So if you using poor quality of lens, the inflammatory cells can actually invade the lens material, and actually cause complete opacification. So always try to go for the ideal and good quality lens. And also we have a we are doing routinely the cataract surgery in scleritis patient. So sometimes the myth is that in scleritis you should not use scleral incision, but sometimes you are like such cases, no, where you have 360-degree corneal thinning and all. So sometimes if your control of the scleral inflammation is adequate, you can actually go for scleral tunnel in these patients where the is not possible. So sometimes you have to be very careful. Not necessarily every patient will require. This is one of our patient. We are thinking whether we'll go for patch graft or not, but finally we could do the surgery. You can see here without doing patch graft and all, the patient is doing well, and you can see that after that in scleritis patient sometimes you need to take a suture because the rigidity of the eyeball is so less. Sometimes you can't rely on that, so you need to take that. So if your control of the scleritis is perfect, don't worry about taking suture and all in such patients. This is again coming to, I'll just touch one point of pediatric uveitis. This is just to show that this patient has been treated with 1 year actually with adalimumab and methotrexate for GIA. So you can say that the child was treated adequately for immunosuppressive. Then I did the cataract surgery and see one eye the child tolerated the IOL very well, and other eye we need to explant the IOL. So one thing to remember that no rule fits all the eye. You have to take an individual decision. So prevent IOL in children with uveitis in following condition: if the AC is very shallow, if there is severe history of inflammation, hypotony, age less than 4 years, don't try to put IOL in children. And also one word of caution for the pediatric ophthalmologists who after doing cataract surgery they do a posterior capsulorhexis and do extensive vitrectomy. You have to remember that in children if there is a vitreitis, then if you do extensive vitrectomy, it can actually cause a traction and cause subsequent retinal detachment. So don't do that. So just to conclude my talk, as is your pre and post-op immunosuppression, so is your outcome in cataract surgery in uveitis. Extensive posterior synechia and macular edema are two important clinical signs that should alert you before cataract surgery. Scleral incision can be used in certain conditions like peripheral ulcerative keratitis and necrotizing scleritis. Large eccentric rhexis can be a rare cause of post-op inflammation, so better to avoid that. And no rule that fits all eyes in pediatric uveitic cataract. Thank you.
Yeah. Wonderful, absolutely. Very, very nice presentation and beautiful pearls shared, Dr. Partho. Quick comments from Dr. Harshul and Dr. Armiya about uveitic patients with cataract.
That was a very nice talk, Dr. Partho. I think what has made our life very easy as a cataract surgeon is the invent of this pupillary expander. So now whatever is the size of pupil or whatever, how much fibrotic it is, how small it is, with the like Malignant ring is my preferred device. I love to use that device, and I can put in very small pupil also. So I think that makes our surgery very simple, and he rightly said that it's not the surgery. Surgery has become very simple with these categories. Release synechias, put ring, and everything becomes easier. But to control inflammation is the key. Like in folks, and those are straight away forward cases, they don't have any problem. But those cases who have chronic inflammation, they need to be medically controlled well if you want to have a good results. That's my take.
Thank you for very much for the presentation. Just to highlight that uveitis, like glaucoma patients, pre-operative and post-operative is more important than like the intraoperative procedure, because you can do a very nice surgery, and second day or the first week, if you didn't control the patient well, everything will back to level 0. So post-operative control and meticulous close follow-ups for the patients and also for the parents, because sometimes in pediatric uveitis the patient are not aware of what is the problem. So if they missing the drops or even the follow-ups, the complication will start, and in a month everything back to 0. So this is very important, that managing the patient and the relatives is the same important as pre-operative and intraoperative.
Yeah, thank you very much. And thank you again, Dr. Partho, for amazing tips. Now we will go to Dr. Aditi, who is going to speak about cataract surgery in presence of lacrimal obstruction, something which is very, very crucial when it comes to the day-to-day cataract practice. Dr. Aditi is a oculoplasty specialist trained at LV Prasad Eye Institute and has been former secretary of scientific committee of the Maharashtra Ophthalmological Society. Over to you, Dr. Aditi.
Good morning all, and thank you Dr. Vardhaman for the opportunity. So even though the topic is actually cataract surgery in NLD obstructions, I would like to give a small glimpse about rest of the oculoplastic comorbidities also, in addition to lacrimal drainage pathways abnormalities. So basically I'll be essentially covering the NLD obstructions along with few eyelid abnormalities and ocular surface tumors. So like just a brief introduction, we have watering patients where the watering can be due to canalicular obstruction, NLD obstruction, or even with the punctal stenosis. So what are our basic concerns in cases with NLD obstruction? Is it necessary to check duct status or NLD status in all the cataract patients pre-op? Which test to perform? Which sac surgery to prefer in cases of NLD obstruction with cataract before cataract surgery? When to operate cataract after the sac surgery? What should be the duration in between two surgeries? And can we operate the eye with cataract surgery if contralateral eye has an NLD obstruction? So like just to address these concerns, I would like to briefly go through evaluation of the lacrimal drainage system, which is important to get the actual diagnosis and then go ahead with the decision making. So evaluation essentially will start from routine tear film height, matted lashes, and then goes to the Roplas, syringing and rest of the investigations. So Roplas is basically regurgitation on pressure over lacrimal sac area. If Roplas is positive on pressing, if some material is coming out, that surely means that canalicular system is patent but NLD is obstructed. So when we do syringing, these are a few important points which we need to see. These are actual steps of syringing. So first is punctum dilatation with Nettleship punctum dilator. Then which type of cannula do we use? Do we use the visco cannula or just a bent needle? Ideally not. Then is this the cannula to use? Even that is not ideal. So what is ideal is a straight cannula, because you can just stretch the canaliculus, make it straight. With the bent cannula, you are going to scrape the canalicular epithelium and going to cause more damage. So what is the proper method of sac syringing? Why do we call it as sac syringing? Because you are supposed to enter the sac and then do syringing and not do from the punctum or just canaliculus. And just like if the finding is freely patent, you can surely go ahead with cataract surgery. In cases with regurgitation, we need to know what is the percentage, what is the kind of regurgitation, and from which punctum it is coming out. So depending on the interpretation, regurgitation from opposite punctum, surely NLD block. From same punctum can be canalicular block. So if it is NLD block, yes, you should go ahead with sac surgery. If it is canalicular block, because the fluid or tears are not reaching the sac, you can safely go ahead with cataract surgery. There is no need for any surgery in spite of the watering. 100% regurgitation, again complete block, less than 100% partial block. If the regurgitation is clear, you can still go ahead with cataract surgery. If there is no obvious mucus or purulent material, maybe you can be slightly cautious with more of an antibiotic cover. Again, similar clear fluid regurgitation. If it is NLD block, even in spite of clear fluid regurgitation, it is always wise to go ahead with sac surgery. And obviously with mucus or purulent, it is obvious that you should go ahead with sac surgery followed by cataract surgery. So these are few things which you need to remember: the type of cannula, the syringe ideally should be either 1 cc or 2 cc and not like 5 cc, 10 cc where you are just pushing the fluid. Again, why probing is important? To see if it is hard stop. Hard stop means canalicular system patent. If you are getting soft stop, it means it is a canalicular block and it is not threat for like patient even if he or she undergoes cataract surgery. So just like skipping this, in kids, if you are not sure or if NLD is patent but the patient is having watering, FDDT can be a good test to see if there is a function lipifora or pediatric patient. It can confirm that NLD is blocked and you need to address it. In cases of punctal stenosis, if after dilatation NLD is patent, it's a safe case to go ahead with cataract surgery. Cases with conjunctivochalasis will cause mechanical obstruction, which will cause watering. So it is always like better to address it, because a patient may relate it to the cataract surgery. If not, like you can easily go ahead with cataract surgery, because NLD is essentially patent and the obstruction is just because of the mechanical conjunctival obstruction. In cases where discharge is there, peripunctal fullness and pouting of the punctum, it is clear-cut case of canaliculitis. You need to do canaliculotomy with curettage, then treat the canaliculitis, wait at least for 4 to 6 weeks for the conjunctival sac to get rid of the microorganisms and go ahead with surgery. So summary for cataract surgery with watering: it is ideal to perform syringing in each case as pre-op workup, or at least see micro regurgitation on slit lamp. It may not be a gross or plus positive, but if you see on slit lamp, many of the cases will have regurgitation which is appreciated on the slit lamp. Ideally, medico-legally better to do syringing in most of the cases. Only canalicular block or punctal stenosis can safely go ahead with cataract surgery. NLD block, SAC surgery followed by cataract surgery. What is the duration ideal? Ideally 6 weeks, but practically you can go ahead after 4 weeks. Why this? The literature says that the conjunctival flora takes almost 3 to 4 weeks to clear after doing the SAC surgery. Otherwise, if there is urgency, you can surely go ahead with additional antibiotic preoperative coverage. Emergency cataract surgery where some phacolytic phacomorphic glaucoma is there, DCT with punctal cautery can do, but again that 3 weeks interval is still there, so be just cautious about use of antibiotics. Now a brief thing about eyelid comorbidities. In cases of blepharitis, what are the concerns before cataract surgery? The concerns are evaporative dry eyes because of the meibomitis and infection due to microorganisms. So it is always better to treat the blepharitis, wait for some while and give additional lubrication, because the evaporative dry eye sometimes takes a bit of more time to resolve even if the blepharitis has resolved. In cases of stye or hordeolum, it is basically infective condition. So, and obviously with the pain and everything, even pre-op assessment will also be very difficult. So better to wait for the stye resolution, then go ahead. However, chalazion is actually non-infective condition, chronic inflammation. It doesn't have active infection. So it's like relative contraindication. When it becomes absolute, except in like cases with large chalazia which may affect your K readings because of the astigmatism caused by the mechanical weight of the chalazion. Now, conditions like entropion, it is obvious, entropion, trichiasis, dystichiasis, it is obviously needed that you treat the condition, which is followed by cataract surgery to avoid any corneal epithelial erosions post-operatively, and which increases the chances of infection. However, in ectropion, like this patient has right eye senile plus mechanical ectropion due to chalazion, whereas left eye has senile ectropion. So in ectropion, if there is no lag of ophthalmos, you can surely go ahead with cataract surgery. It's not like entropion. But sometimes gross ectropion may cause difficulty in inserting the speculum and retention of the speculum if it is like extreme ectropion. So you need to address that before, because of the technical difficulties during the surgery. Now just how do I play this video?
I think you'll have to go with the cursor.
It's now it's showing. Yeah, you can play both if it is. So this is basically a patient of benign essential blepharospasm, where you can actually see the spasms. Patient also has a component of apraxia of lid opening. So these cases, there is surely a technical difficulty for preoperative accurate workup, and even during the surgery also it may pose some problem. So these patients, it is better to go ahead with injection botulinum toxin, wait for 1 to 2 weeks, then go ahead with preoperative assessment. maybe if the patient has lagophthalmos because of the botulinum toxin, it generally clears off within a month or so of injection. It is better that after a month you directly do the surgery, because the blepharospasm patients, the Botox effect is very short-lived. So before it recurs again, it is better to do the surgery. Then concerns about like ptosis, it can be pre-cataract surgery or it can also develop post-cataract. If it is pre-cataract, it is moderate or severe. It is always good to go ahead with ptosis surgery, which is followed by cataract, for two reasons: because the pupillary axis is clear, then only patient is going to appreciate the change in the vision. Other thing is again induced astigmatism due to the mechanical pressure of the eyelid. So if you do it later, patient may have some different K readings. It can be troublesome. Sometimes post cataract surgery, patient comes with mild ptosis, which can be surely corrected later with LPS reattachment. So basically, what are our major concerns in ptosis post cataract surgery? Most of the times it is not mentioned in the informed consent as a post surgical complication, and these days patients are concerned about their looks. Generally, there is no photographic documentation in cataract surgery by the external photographs, because that's not a routine for all cataract patients. So it is always a subjective perception. The etiologic factors for ptosis are unknown, even though there are few hypotheses. So because of lack of knowledge about the etiology, there is a bit of no clue about how to prevent it. The theories are speculum theory and bridle suture. However, now bridle suture theory doesn't hold true, because anyways we are not using bridle suture, but still see ptosis post cataract surgery. Now the last case scenario I would like to come to. So this elderly lady came with bilateral defective vision and was wanting to undergo cataract surgery, but careful evaluation actually showed a keratinized lesion, conjunctival lesion with feeder vessel. So this was actually OSSN. So in hurry to actually work up for the cataract cases, every time OSSN need not be limbal lesion. So it is always good to assess the overall surface. Because of these concerns, you can actually make extraocular tumor intraocular by seeding, and obviously wait for 3 months to check if it is not recurring, and then go ahead. Obviously base and margin clearance is important. So to conclude my talk, careful evaluation of ocular adnexa is very much essential before cataract surgery. Customized approach depending on the diagnosis or comorbidity is extremely important, and proper counseling of the patient is important, because sometimes the patient has come for cataract surgery, but you are advising some other surgery. So these days it is very important to explain to the patient that why this needs to be done before cataract surgery, in order to avoid losing the patient to some other surgeon. Thank you so much.
Thank you so much, Dr. Aditi. I think it was very nice and quite a protocolish presentation. Very nice, a lot of pearls shared. I think because of the lack of time, we'll go to the questions at the end. We'll go next to a very close friend, Dr. Harshul Tak, who is a master of doing cataract surgeries, especially in difficult, challenging situations. Is the best person to talk to us about how to perform cataract and get optimal outcomes in presence of ocular trauma. So over to you, Dr. Harshul.
Thank you very much, Dr. Vardhaman, for including me in your course. So I'll be taking you through 3 or 4 traumatic cataract cases, different scenarios. We all know that penetrating or ocular or blunt ocular trauma can lead to traumatic cataracts, and it can present in varied form. So this is the case, a young female, 28 years old, who had this thorn injury. You can see here on cornea, there is a penetrating injury which occurred, and within 2 days she developed the cataract like this. So whenever we have a case where the anterior capsule gets ruptured, so we know that the cataract, it forms very fast, so we need to take care of this cataract. But we know that anterior capsule is ruptured, so we always have to counsel the patient about that the PC may be ruptured. We may have to do posterior segment intervention. We may have, so all the options have to be discussed with the patient. That is, very crucial in scenario like this, because once we go in, once we take out this fluffy cortical matter, then only we come to know that what is the status of the posterior capsule and whether vitreous is there or not mixed with this cortical matter. So let's see how the case proceeds. So it's important that once I make side port incisions, you need to be very careful that you don't damage further. So just make side port incisions, and after making this, I see this fluffy material, so I just, and this is under just topical anesthesia which I am doing, and here I am just putting some saline there so that the extra fluffy material which is there, it gets washed off and comes out and I can see the capsule clearly. And after that, I'd like to stain anterior capsule, which is very important, so that you can map out that what is the extent of the tear which is there. So all this fluffy material, it's coming off once you stain, and after that I go ahead and put viscoelastic. But remember that don't put much of the trypan blue, because it may, if there is a zonular dialysis, it may percolate behind and may cause issues with the visibility. So here I'm just making this main port incisions, and I can see that my anterior capsule is torn here like this. So you have a split there in the anterior capsule. And another principle which you have to remember is that always try to maintain closed chamber, because these are the fluctuation of the anterior chamber which may cause vitreous disturbance if it's not disturbed. So slowly I go ahead and put irrigation cannula and try to take off this fluffy cortical matter. So I've not done anything here, trying to make any capsular excess, because I can see this split here, and I'm just releasing this synechia which is there. So you need to be gentle, you need to be meticulous. So just take off the cortical matter, going from different port. So you need to go very slow. And here, this is my viscoelastic cannula. So you can see, I just go ahead and put some visco beneath the anterior capsule and the entire fluffy material. So this is visco expression which you can always do, and because of the curve of this, continuous curve of this cannula, you can reach till the equator also. So I take off this fluffy material, again going with viscoelastic cannula, putting, so I'm maintaining closed chamber and try to take off the fluffy material. So again visco expressing the cortical matter. So in the end I have, as you can see, on one side I've taken off the entire cortical matter, and again change my hands, and so you can see a very big split there in anterior capsule, but posterior capsule is intact, and there is no wraparound tear at this stage. So we always have to, that's the importance of maintaining closed chamber at every point of time. So once you clear off the entire cortical matter, I'm just seeing the extent of the tear on both the sides using Kuegelin's hook. So I can see that it's limited till equator. So in scenario like this, you can easily go ahead and put a single piece IOL encapsular bag with the haptics perpendicular to the where the capsular axis is torn. So I go ahead and I'm not rotating the the lens here. I'm just bending the haptic and pushing it in the capsular bag, so that you don't have those rotational forces. So once you have IOL in capsular bag, you can see you can go ahead and use micro scissors to cut on both the sides and try to just enlarge the rhexis. I go on other side also and just make capsular axis of adequate size. So again in the end, take off all OVD and just maintain closed chamber, put irrigation cannula inside, and you can hydro stitch your incisions, and this finishes the case. This is another case which had trauma, blunt trauma, and presented, I think, 2 to 3 months after trauma. And you can see that because of this blunt trauma, the patient had subluxation. So it's very important that you dilate pupil nicely and see that how much is the extent of subluxation. Here the subluxation was more than 5 to 6 clock hour, and also there was fibrotic anterior capsule. So whenever you are dealing with the capsule like this, fibrotic capsule, it's really difficult to make capsulorhexis. So remember, through fibrotic area you need to cut with micro scissors, so you need to go through different ports. So when I reach in the area of non-fibrosis, I try to fashion capsulorhexis using forceps. And after that, once you reach in the area of fibrosis, you may need to use bimanual technique, keep holding flap with one hand and go with left hand, and so you need to go through various angles, and if needed 1 or 2 extra side ports are also essential to go through correct angle. Once you reach in the area of subluxation, remember we need to put capsular hooks here, so you need good tissue rim of 2 millimeter of anterior capsule here. So cut through this area. So here I have a good capsulorhexis. Go and put some viscoat there to tamponade anterior vitreous phase. And depending on area of subluxation, you may need to use 2 or 3 capsular hooks depending on area of subluxation. So here I go ahead and put 3 capsular hooks in the area of subluxation. This is important to support the capsular bag in the anterior posterior direction. And most of these traumatic cataracts, we know these are brittle, they are softer ones, so nothing great in chopping this nucleus, but still you need to again maintain closed chamber. That is very crucial, that you don't let antechamber collapse at any point of time. So once I take off the nucleus, I go ahead and put viscoelastic, and now the job of these capsular hooks is over, but you need CTR ring here to centralize the capsular bag to give it equatorial support. So I go ahead and put this CTR ring. If you are comfortable, you can use Sioni CTR, because in the end you need to fixate this capsular bag. So you just use Kuegelin's hook inside and put CTR. So once the CTR is placed, you have capsular bag nicely stretched. You take off all cortical matter nicely. And now is the time to put capsular tension segment, so that for long-term stability we need to anchor this capsular bag to sclera. So this is a 90 proline which I am using. Now I started flanging these CTS segment using 50 proline suture, but this was before I was using 90 proline. So you pass this double arm suture through eyelet, put this segment in capsular bag and railroad both the ends either through Hoffman pocket, or this is the 1.5 millimeter behind the sclera. I made the scleral groove. So once you railroad both the ends of the proline suture, you just titrate the tension and tie a knot there and bury this knot in scleral groove. So now you have this segment fixed nicely to the scleral wall, and which gives us long-term stability. And this was a traumatic cataract, so I decided to go ahead and put a single piece IOL in capsular bag. If it's a progressive zonulopathy, you may choose to put a 3-piece IOL. So here again IOL goes nicely in capsular bag, and this finishes the case. And I think one last case I'll just like to show quickly in few seconds. So many times you may have a traumatic cataract along with some iris defect, the traumatic mydriasis is there. So you may need to do pupilloplasty in these cases. So nothing great in chopping this nucleus again is a traumatic cataract. So once you put IOL, then I try to constrict the pupil. So this is single pass 4-throw pupilloplasty, which is taught by Dr. Amar Agarwal, and it's very easy to use, and Everyone should learn this. It's quite handy in many cases like traumatic mydriasis or even post angle closure glaucoma attack cases comes which have fixed dilated pupil. So you just go ahead and pass one, there's a 90 proline through one of the side, and through other side you pass this arm, and you take out this loop from this side of the iris, and once you take out this loop you give 4 throws of this proline suture and give 4 throws, and then you just pull both the ends and your job is done. It's very simple. Yes. So just pass 4 throws and you tie a knot there, and depending on the iris defect you can go ahead and do 2-3 times, and again I'm passing one more round there. So in the end you have a pupillary iris defect which is closed nicely. So I think with this I'll end my presentation. Thank you so much for giving this opportunity.
Thank you, Dr. Harshul, for showcasing very challenging scenarios and giving them very optimal outcomes. So because of the constraint of time, we'll go to the questions later. We'll go to the next talk by Professor Ashraf Armia, who is an internationally reputed cornea refractive surgeon, also has expertise in glaucoma. He comes all the way from Egypt, has been known to me for a long time, and we have had association also through Jerso, where he's very active in conducting very large-scale webinars. So we are very happy to have Professor Ashraf Armia, who is going to speak to us about cataract surgery, especially in eyes with keratoconus.
Good morning. Thanks, Valdemar, for the invitation, and thanks for the IOS. And this is my first time to India, to New Delhi, but not to India. I will give brief what I'm doing in my practice. I'm not going to take it theoretically. This is what I'm doing exactly. I'm working keratoconus, I think, since 22 years now, and we have a school also for training globally. I have no financial disclosure related to this presentation, but these are my disclosure to companies that I'm a consultant and speaker to them. So since in the last 5 years, a lot of changes happened, and we did a huge work with Cosimo Mazzotta. We published a lot of papers related to keratoconus to improve it. And lastly, we published, this is the new innovation for the ray tracing transepithelial excimer laser. It is going to change a lot of issues in refractive corneal surgery in keratoconus. And with the new machine, the AIOS, everything will going to be changes nowadays. And we are happy that this also was top-cited last month is with how early diagnosis with the corneal epithelial thickness mapping. This is a very nice publication, and I encourage everyone to read it. It's a very nice one. So let's start. As we know that cataract surgery in keratoconus is, the prevalence is more than other patients without keratoconus. And this is how the literature says. And this is my lighthouse for the cataract with keratoconus. In my opinion, after all these years, so you divide it into history of good corrected distant visual acuity, history of low advanced. If it's manifest equal the topographic, you go for cataract with toric IOL. If the manifest is not matching with the topographic, you go for cataract monofocal, and if there is any residual, you can go for toric ICL. If it's the history of low, so the irregular cornea, definitely don't go for cataract unless they make the cornea regular before you go for cataract surgery. So the challenging in cataract with keratoconus, 3: preoperative, postoperative, intraoperatively. And this is what I'm going to highlight in my presentation. So preoperatively, as I'm seeing all of my patients, that the challenges is astigmatism, stability, and IOL calculation. These are the 3 main challenges that facing any surgeon doing cataract with keratoconus. So why ectasia? If we think that progressive corneal ectasia, this is how the process goes. Myopia, irregular astigmatism, wide range of case values in a small area. This is the main problem in the calculation, changing in the anterior chamber without, which makes it more difficult to calculate the effective lens position. So if we think about keratoconus, it's like corneal ectasia is common, post-operative surgery ectasia resemble the keratoconus, and keratoconus resemble the corneal ectasia. all of them leads to IOL calculation problems. So stability is very important before you go for cataract with keratoconus. Calculate the lens when there is a confidence of cornea stability. Never calculate the lens in a fluctuating cornea. Advise patients with a small rex that decompensate the cornea, and we are going to highlight also that this is a common problem. And to have the stability, you need 3 pentacams, 3 different topographies in every 6 months, so 1 year and a half. Why there is a challenging in the biometry? Because the steepest cornea and the off-centered apex make it difficult to obtain accurate keratometric readings. Why? Because the aesthetic eyes have higher axial length and deeper anterior chamber. So this makes the effective lens position of the lens calculated will not going to be properly presented. As the apex is off-centered, it might not be the visual axis, and this means that the case is not the proper. So the accuracy, we started by the Barrett, and we worked with this for many years, but we found a lot of problems still. So after this, in 2019, came another calculation and give this nice categories. They categorize the patient category 1, 2, 3, and 4 according to the corrected distant visual, and this is how we are going to do it now. But recently, after many formulas, cane formulas nowadays came that it's the most acceptable biometric calculation in patients nowadays. And this is the most important formula that you are going to calculate your patient with keratoconus in cataract surgery. And this is the online calculator for the cane formula. But they now we should advise that if you are going to use the cane formula, use this. If it's stage 1, no adjustment. If it's around less than 50 or 48, 49, it's okay. But if it's you found the patient at stage 2, calculate the patient and leave the post-refractive residual spherical error minus 0.75 to up to minus 1.5. If it's advanced keratoconus, leave the patient with minus 2 to minus 3 acceptable, and never leave the patient hyperopic post-operatively in cataract with keratoconus. And if we are going to look for the astigmatism, if the patient is irregular astigmatism, we don't recommend for cataract with keratoconus to put a toric IOL, and you should do the astigmatic measurement for the patient with keratoconus with different machines to reach probably the proper axis and K1 for the patients. So the significant correlation between the total cornea astigmatism and the anterior cornea astigmatism and posterior cornea astigmatism is very important if you want to calculate the total corneal power astigmatism. So the use of toric IOL nowadays in cataract with keratoconus with low-grade astigmatism and regular corneas in keratoconus. Intraoperative tips, this is my tips. Early keratoconus, like normal cataract surgery. If it's severe keratoconus, so it is a trouble. Why trouble? Because the distortion of the vision. So when main incision is performed, it definitely changes the structure of the cornea. So according to the main incision, according to the where is the cone, this is very important. You choose superior or superior temporal if they have an inferior temporal cone. If it's a rare superiority in keratoconus, do it temporally. Cornea scarring is an issue in keratoconus, cornea keratoconus, so place 90 degrees apart from the cornea incision. This is important. Inferior scarring, so the superior approach is not advised because at the end of the phaco tip, we're reaching the opacity. Keratoconic corneas and thinner fropula, so also well steep, two steps cornea incision is crucial, and suturing for advanced keratoconus is very important. Diffuse scars, very important, that's worse under the surgical microscope. So putting different light sources is very important, and lighting from the side is good. And also spreading of the dispersive viscoelastic is crucial, like the methyl-cellulose, because it gives mild magnification and intraocular viewer. Also staining of the capsule can help in the visualization in advanced keratoconus. In my opinion, whatever you do in toric IOLs, but narrowing the pupil is important, either by the IC8 from the IOL or you do the pinhole papilleplasty, as Ammar Gwaral mentioned in the last 2 years. I found in all my cases with advanced keratoconus, I do all the cases, even if I'm putting a toric, I do pinhole papilleplasty if the patient around 2 to 3 millimeter post-operatively. Post-operatively changes, two changes: cornea ectasia, progression after cataract surgery, which is less common, but it can happen, and management of the residual refractive error. Why it happened? Because it triggered the cataract surgery, triggered the biomechanic stability of the cornea, and it caused mechanical stress. Also, cataract surgery can cause also surgical inflammation, and very rare cases it can cause to late progression ectasia. How to manage the residual refractive error? This is what I'm doing in my practice. If it's a non-surgical option or surgical option. If it's non-surgical, if it's mild, spectacle is very, very nice tool for the patients. If it's higher astigmatism, rigid contact lens, because these patients are used to do rigid contact lens before. If it's options, two options. Either you do IOL exchange, which is 26% of the patients we do this, or secondary IOL. And if it's secondary, additional toric IOL, as it mentioned, is a very good tool, and also the ICL for the high spherical post-operative results is good tool for correction of the residual post-operative astigmatism. So my take-home message: in keratoconic eyes, optimizing the IOL power calculation is certainly vital importance in the improvement of surgical outcomes, ultimately patient satisfaction, and the keratoconus can cause multiple sources of keratometric and biometric errors. Finally, this is a very nice book. We made it with Cosimo Mazzotta. In 1 year, we got more than 10,000 sellers in 1 year only, and it was a huge collaboration with more than 50 of the people doing keratoconus globally, and I encourage everyone to take this book. And this is the MIOM meeting, and the AIOS is already have an MOU with us in Dubai. We have last year, a lot of Indians were coming to Dubai last year, and a lot of speakers, and also young ophthalmologists were coming from India. So I encourage everyone to go through this and be with us this year also in Dubai. Thank you so much.
Thank you very much, Professor Armi. I think it was an amazing, great overview, and with your extensive work, you made it look very simple, but great pulse shared. So now we'll go to the last talk of this IC, which is the cataract surgery in eyes with previous refractive surgery. Friends, if you look at this full timeline, you will see that from the era of first posterior RK, which was actually done first time in Japan in 1920, almost a century back, to today's times, smile and contour procedures, we have truly come a long way. But in this entire armamentarium, actually this was the procedure which actually changed the aspects of refractive surgery globally. And this is the first LASIK done by my mentor, Professor Ioannis Palikaris, and this is the first historic video done on the Greek woman. So this was the day when actually the refractive surgery became a magical global phenomenon, where millions of people as of today have undergone a very successful spectacle correction with a very pen-free and very safe procedure. Because it became a global phenomenon, that is also the reason that people who have tested the success of LASIK for the first time in their life in 1980s and 1990s, who were called as the baby boomer generation, are the ones which are coming back now today for a cataract procedure. And what we have to know, that these people are special. When they come for their cataract, they have a relative lower tolerance for diminution of vision. They are the ones who will come back for early intervention, and they will be extremely demanding because they have seen excellent outcomes of their previous LASIK procedure. However, the irony is that in the patients who desire the most accurate postoperative refractive results, the IOL calculations are least predictable. And the measurements of this corneal power is difficult because of variety of scenarios. That is what we are going to look at now. However, what we have to first understand is how a virgin eye formula works, and then we will go to how the post-LASIK changes occurs. You see that the regression analysis is a very popular formula of the past, such as SRK, SRK2, in which there was a accumulated data which was actually accumulated together to come to this formula. And now new formulas, they rely on theoretical formulas which depend on the concept of the ELP which is the effective lens position, which is the distance between your anterior refractive surface of the cornea and your nodal point on the internal natural lens. So, this distance, which was presumed to be constant at 4 millimeters in the past, but it was seen, of course, that as you have a shorter eye, it becomes smaller than 4 millimeters, and when you have a longer eye such as myopes, it actually becomes longer. So, this ELP prediction in variety of these formulas depends on many factors, many parameters that we look intraocularly for these patients. So, when we understand now how the Virgin formula works, now let us understand how and why the IL power calculation is different and difficult after excimer laser procedures such as PRK and LASIK. There are three sources of formula. The number one is the K reading error, which happens because normally the cornea is going to justify and going to follow this K reading let's say formula, which has proportion of anterior versus the posterior radius of curvature of 1.21. But what happens in people who have undergone a myopic LASIK, the cornea becomes flatter anteriorly, and that actually causes a overestimation of keratometry because that ratio goes haywire. As against that, in patients who have undergone a hyperopic LASIK, it becomes flatter, therefore it causes underestimation of keratometry, thus leading to hyperopic surprises in myopic patients and myopic surprises in past hyperopic patients. The second error is the topography error, because you know that the real keratometry, which is most important for us, is from the center of the cornea, but all our topographers are actually taking it at 3.2 millimeter away, and that is why we get the second error. And the most important error is the formula error, and that happens because all our ELP prediction formulas depend on keratometry, as you can see here, except for Hegge's, and therefore all this formula will lead to erratic outcomes with your IL power calculation. So, in general, if somebody has undergone a myopic LASIK, the patient will have overestimation of keratometry, underestimation of ELP, that leads to underestimation of IL power and thus leading to hyperopic surprises. So, how do we calculate the IL power in this scenario? The easiest way, of course, is to use the Hegge's formula, because the Hegge's formula does not depend on keratometry, and that can lead to good outcomes. But if you don't have access to the Hegge's formula, then we have to go to the Aramberry double K method for all the K dependent formulas. The Aramberry double K method will depend on the preoperative keratometric reading, which is taken from for the ELP prediction, and the true postoperative keratometry reading, which is taken from the pentacam to use in the formula for calculation of IOL power. And when you use this dual Aramberry keratometry formula, then you actually can get very good outcomes. And these are series of different formulas which are actually currently working on advanced level to give very predictable outcome for patients who have already undergone LASIK surgery. Fortunately for us, all these formulas have been clubbed together under one umbrella on this website of ASCRS online calculator, and this actually gives a very good display of minimum, maximum and the median IL power that you will get for these patients. If you look at the studies done, then currently the OCT and the True K no history formula have been seen to be the best, especially the Barrett's True K formula is currently one of the best formulas that you can use. But what happens in post-RK patients? The post-RK patients, along with the first three instabilities, also have a lot of corneal instability, and thus leads to highly irregular, highly erratic outcomes when it comes to the biometry, and only 65% cases have shown a ±1 diopteric accuracy in patients who have undergone a past RK. So let us look at this 34-year-old female who had undergone a 16 incision RK like this, and you have to see that she has an extremely small optical zone, has a grade 3 or grade 4 brown cataract, and has led to a lot of differences in their IL power when it comes to both IL master as well as when we have seen through even the ASCRS formula. So in these patients, even the ASCRS formula does not work very well. So this is a small just a overview of post-RK cataract surgery is done. You can see that there are multiple incisions which have been done right from the limbus till almost till the internally to the optical zone. It's a lot of fibrosis around there. You have to be sure that you have a slightly larger axis, because we are dealing with a very brown cataract. You have to make sure that you do not make a clear corneal incision when it comes to your main port, and make a scleral incision only. And of course, you have to rely on the direct chop technology techniques, and use plenty viscoelastic to actually remove this cataract in very safe manner. But what is most crucial here is not only removal of cataract, but also how are we going to deal with the biometry. And I'll share one tool, one trick with you. is that whenever we deal with patients who have more than 12 incisions, actually the biometry doesn't do very well. So at this point, I hydrate the incision, I leave the patient aphakic, and then the patient comes back for a post-operative or intraoperative retinoscopy, and we use what is called as a Maloney's method, where you actually do intraoperative retinoscopy, multiply by 1.7 or 1.8 times, and that is how you select your diopters. And then you go back again with the patient at the same time, or you can also go back the next day and again refill the chamber, implant the lens which has come through this new pearl of intraoperative or a post-operative retinoscopy related IL power calculation. And when we have done this kind of calculations with the retinoscopy dependent IL power calculations, we have seen extremely good outcomes. In fact, as against the literature, our outcomes in 38 patients that we have seen so far are more than 90% patients are within plus minus 1 diopter. When it comes to intacs, actually the IL power calculation is very similar to the post myopic LASIK patients, and most important thing that you should know is that patients who have undergone an ICL implant do not require any change in their biometry, and the same formula can be used as directly from the IL master itself. In terms of the IL choice, in hyperopic eyes, you have to choose post hyperopic LASIK eyes, you must choose a non-aspheric lens such as a Sensar, no financial interest there. But in myopic patients, you should go for lenses which have a negative asphericity. For example, the Technis AMO is the lens of choice for me, and patients who have corneal aberrations or post-RK eyes, you should go practically with a zero aberration lens, and patients of course who have a significant astigmatism, you can stick to the toric IOLs for them as well. So this was a small overview of patients post refractive surgery, and I would like to also thank all my co-moderators and co-instructors, and probably we can have a very short group photograph before we give the stage to the next session, please. Thank you. Thank you very much.